Next up, we'll be focusing on the pharmacy response to optimise medicines in care homes. And I'd like to invite Lelly Oboh, consultant pharmacist from Guy's and St Thomas's, to deliver their session. Thank you, Lelly.
Oh, thank you, Mojigan, and thank you everyone for tuning in. So my name is Lelly. So my day job is, no, not the next slide, the slide before. Yeah, so my day job is working as a consultant pharmacist and older people at Guy's and St Thomas's NHS Foundation Trust, but also I have a day a week to work with the specialist pharmacist services, providing advice on all things to do with old people and medicines. But also in my local integrated care system, I'm the clinical lead supporting the medicines optimization in care homes pharmacists. So as you would know, once COVID started, care homes took a big hit. Not just the residents who where we had the highest mortality from COVID, but also the staff were overwhelmed and they were facing significant challenges in their day-to-day work because of the pandemic. But also we know that about 40% of the care homes work, staff work, is around medicines and just managing medicines, giving to staff and managing all the processes around medicines. So this was a huge challenge for care homes. We know that a lot of the patients who were having COVID, and indeed not even just those, but even the other vulnerable care home residents do take more medicines than any other group of people out in the community. And we had problems like people have mentioned with shortages. The COVID death was very rapid and we needed medicines to be on hand within hours. And on top of that, we had the GP practices and community pharmacists who were just as overwhelmed with work. So things were quite tough during then. Healthcare staff like pharmacy staff and GPs and geriatricians were unable to get into the care homes and literally be the second eye to keep things around medicine. So we had our local pharmacists not being able to go in and keep an eye and, you know, pick up things that the care homes wouldn't have time or the expertise to pick up. So this was kind of a really crucial time. So it wasn't surprising that we had an NHS e-letter that called to community health services and primary care to support care homes, not just the residents, but also the staff. They were supposed to be proactively providing timely clinical advice and proactively supporting staff and residents through, for example, just weekly check-ins, and also looking and supporting the staff to help to manage people who had suspected COVID or confirmed cases of COVID, or any other patients with that was identified as a clinical priority through remote reviews and assessments. And part of that was the pharmacy medicines review. Next slide, please. So the aim really within that letter from the NHSE specifically said there was a bit calling pharmacists to set up a model to reduce risks of a medicines-related risk in care home, but also to support them to meet the care home staff and their residents' needs. So we had to set up this process within 14 days. And so how were they to do this? This was all through leadership. So my talk is going to focus on leadership and how we got round to meeting this aim just by leadership. So we had to have a collaborative, clinical and professional leadership approach right across all pharmacy sectors. And we're supposed to be supporting and rapidly mobilizing the people you see in green who are the front-facing pharmacies at care homes. So it's the CCG pharmacies, the PCN pharmacies, primary care networks, or the pharmacists in GP practice, or the pharmacists in the care homes already. And we're supposed to be mobilizing also other pharmacies who were specialists or hospital pharmacists and those in the mental health trust, community health services pharmacists, and also community pharmacists as well. Next slide, please. So what was the plan? So we were supposed to get really senior pharmacy leaders to rapidly mobilize local teams to support care homes in 4 main areas. Number one, getting supply of medicines in a timely way to care homes, especially end-of-life drugs, delivering a structured medication review or SMRs, which the GPs already had to do as part of their contract starting from October, but also to review the new residents and those who had been recently discharged from hospital. As you can imagine, there was all the COVID-related needs that they had that needed medicines to support or to control symptoms. But also a lot of people who had been coming from hospital might need to be reviewed in terms of what medicines they needed to stop or even adjust as well. We're also supposed to support set up systems around helping the care homes around their queries and any other needs that they had around medicines. And then there was so that was the role of the leaders. But on the ground, the local teams had to implement a service model that had 30 action points. And those action points were around leadership, workforce, medicine support, clinical pharmacy, training and education as well. Next slide, please. So how was this supposed to work? So we had a tripartite Southeast London SEL leadership, and that consisted of the ICS chief pharmacies. We had somewhat representation from the Mental Health Trust. We had representation from the local CCGs or the boroughs, and we had community pharmacy LPC representation as well. So I was co-opted in as the consultant pharmacist to clinically lead this whole initiative. I was supposed to establish a task force from the 6 boroughs and also chair that task force. If you just press for me, please. Yeah. And I was supposed to be also feeding back and working with the London region care homes working group, was the short life working group, also liaising with the borough chief pharmacies, looking also at the wider borough teams who were involved with care homes. So it's the care homes clinical lead, the local authorities, the care home boards, and the care home managers themselves, as well as linking with all other pharmacies in the different sectors. Thank you. So literally, I was almost kind of redeployed to lead this piece of work professionally. So we had a task through the task force. We needed to produce a detailed plan, ironing out or indicating what the SEL leadership had responsibility for, what the task force had responsibility for, and what the local boroughs had responsibility for. Then we had to identify the gaps and make recommendations to the SEL, and then identify what areas of best practice we could share across the STP using a do once and share approach. Then we had to coordinate all the borough responses and feedback to the SEL, to the London region, and to the chief pharmacist. So there was a lot of people to be kept informed of what was going on, because this was a really urgent response. Next slide, please. So this is an example of the monitoring form that we had to that I had to present to the board. So as you can see, those are examples of some of the tasks within the 30 actions. And then we were very clear about who was supposed to lead on that. We had a very detailed delivery action plan, and we had deadlines, and we had to show where each borough was. And at the end of the day, that was taken to the leadership group. And if there was any comments or any actions for them to take forward, it was right there, and it was really agreed. So what did we actually achieve? So there were kind of early wins, and we're still getting some wins even up till now. So for the first time, we had Southeast London-wide pathways and processes. So we have things around care home queries and how they refer patients, how we find out who are new residents, and how we identify people who were being discharged. And everybody was doing this in their own way and phoning, and it was so tedious and long. And we just had the one system. We were able to identify who particularly our mental health and learning disability homes were, which we really didn't know much about. We were able to get a single contact through our Trust Medicines Information department to get a single telephone contact for anybody who had specialist or complex queries around medicines. We developed Southeast London-wide resources and templates, so things around the drug reuse, multidisciplinary team contacts for each borough and SLE-wide. We developed processes for medicines reconciliation. We did a workforce gap analysis, and we even, some of the boroughs did a local care homes needs survey. What was it that they wanted for pharmacy? all in this short time. We were also able to develop primary care pharmacies, signposting resources, and we had a series of about 6 or 7 webinars, all led by our local consultant pharmacists, to cover the main areas that people in care homes would be suffering from. So again, that was very well received. It was all recorded so people can go back and learn from them. But also we've been able to have PCN pharmacy virtual networks. So we have pharmacies virtually networking and having scheduled meetings. And so there's PCN pharmacies, CCG pharmacies, community pharmacies, and having a place where people could bring their needs and discuss pharmacy issues. What were the challenges? There was intense pressure to urgently deliver on a novel and a complex, faceted problem with all the uncertainties of COVID-19. It was really difficult to manage new relationships and work across boundaries, especially virtually, and it was really interesting. We had barriers. We found out that the barriers to implementation were really at borough level rather than pharmacy level. So pharmacies where after a while we settled down, we knew what needed to happen, but actually implementing that at borough level was quite tough. There was all variation in the leadership skills of the borough leads to drive complex change. So some were more experienced than others, and there were just a whole lot of uncertainties that were beyond our control. How do we engage with the PCNs? How do we get commitment? And there was no stick. We just had to nudge versus mandate. And so all this all this happening was based on trust and building relationships. Next slide, please.
Sorry, Lelly, you're coming to an end now. Is this the last slide?
Yeah. Move on, I'm afraid.
So that's fine. So this just one more. Oh, okay. You've tuned me out. Okay. No, I just want to
share your slides
okay,
later as well. Apologies.
Okay. No, that's all right.
Clearly a really important sector around care homes, and many challenges that you've had to overcome.